with you all this afternoon at your Lunch and Learn session. So, as Vaughan said, my name's Donna. I'm a psychologist, a psychotherapist, and a coach. I run my own business, but I also have an honorary position down on the South Coast in acute mental health, and as Vaughan mentioned, at Birkbeck too, where I support occupational psychologists in training. I guess my stance is that I truly believe that we bring all of ourselves to work, and my work is founded on that belief. So therefore, we bring our strengths, our vulnerabilities, and everything else that comes in between. Today's presentation is about doctors. However, I would think that the findings are most generalisable, and therefore I hope of relevance to you all, irrespective of your profession. Being a doctor is widely recognised as a highly respected career. It offers societal status, financial security, and in general, a deeply rewarding experience of helping others. But it also demands a lot too. Whilst doctors are typically high achievers, responsible, driven, self-critical, and occasionally self-doubting, they're also fallible, like all human beings. And yet for many, being unwell or asking for help sits quite uneasily, and it can feel like admitting a weakness, and this doesn't come naturally. And so I suppose this complexity and blend of qualities, emotions, expectations that all come with the doctor at work every day was a focus of interest for me. So I'm going to be sharing some research that delves into what happens to a doctor or when a doctor makes a mistake that in most cases results in life-altering consequences or even the death of a patient or service user. So the World Health Organization, which has been in the news for other reasons over the last couple of days, set a vision in 2021 to 2030 in their Global Patient Safety Action Plan of a world in which no one is harmed in healthcare and every patient receives safe, respectful care every time, everywhere. In the United Kingdom, patient safety incidents continuously rise every year, according to NHS England, and this causes distressing outcomes for patients and family. But psychological distress and suffering also affects the responsible healthcare professional. So as we can see from this picture here, the first victim is the patient or the family. The second is the doctor or the health professional who makes the mistake. And the third victim is the trust, the organisation who often has to defend the litigation process that follows. This photograph actually captures one of perhaps the most notorious second victim cases, that of Dr Hadiza Bawagaba, who, when she'd recently returned from maternity leave, was covering the work of two other doctors and an on-call consultant in her trust. Dr Bawagaba made mistakes in the care of the 6-year-old young man, Jack Adcock, and at the same time there were also hospital-wide IT failures. This photograph was actually a placard that was taken outside the High Court back in December 2017, where the case was being heard. My research is qualitative, and it's always customary to sort of share what brought you there, what led you to want to research something such as this topic. Although I have the title doctor, I'm not a medical doctor, as you've heard. But my career in the NHS began in 2003 within the people and culture function, where I work to support individuals and teams. In 2007, I joined the King's Fund, and so within the team that I worked in, we collaborated with NHS organisations across acute primary care, community mental health systems, and also the whole system. Throughout my work there as a senior consultant and coach, there was one reoccurring theme that really stood out for me. And that was this: clinicians that had experienced trauma often found themselves unable to access support, the support that they needed to be able to process and make sense of their experience. Some managed to process their grief through writing, and one example of this is Mr. Henry Marsh, and he was rather a local hero in southwest London where I grew up. Many of the lives of the community were saved by his and his team's pioneering neurosurgical work. And yet his book, Do No Harm, if you've read it, you'll know that he and his team were able to save many lives, but there were many lives that they couldn't. And his honesty and vulnerability in sharing those experiences really resonated with me. So, inspired by my work and moved by, I suppose, the raw authenticity of Marsh's book, I felt compelled to look at this further. Eventually, I sat down with Professor Michael West, who was a colleague at the fund at the time, and I gave him 7 ideas for my PhD research. And with his characteristic wisdom and kindness, he said, Donna, you can only do one of them. Which one are you going to do? Which matters most? And I think along with my own coaching that I was accessing at the time, I had to think very much more reflexively about where was this need coming from to do this research and what was it in service of. Thinking back, the reason became very clear. Growing up in a village, it was a village then, it's probably now a suburb of Greater London, our family GP, a pillar of a close-knit, predominantly Catholic community, died by suicide. And this same doctor had delivered my younger brother in my parents' flat, and his death sent absolute shockwaves through the community, leaving sadness and unanswered questions. And even as a very small girl, my innate curiosity made me wonder why, what was wrong. Years later, these unanswered questions became the foundation of my research, and under the wise guidance of Jo, who's here in the audience today, Dr. Rachel Lewis, um, and also Lilith Wiley, who's in the bottom left-hand corner of this slide, whose work on stigma and prejudice and sticky reputational stains really informed my approach. And so I embarked on my burning mission to understand and address some of these issues. So what I found was a lot of research had been done on second victim phenomenon, but very little of it focused on the doctor and certainly the doctor or physician in the UK or in the National Health System. And this gap was highlighted by my systematic literature review. To date, there haven't been any published qualitative studies exploring the lived experiences of UK NHS doctors who become second victims. And I deliberately wanted to look at that, not because it was just a gap, which is always helpful in doctoral research, but also I really wanted to understand and have conversations which had a purpose. I wanted to hear the words, the imagery, the raw experiences that the doctors that I spoke to keenly shared, and to understand how these insights could perhaps perform improvements within the workplace. It also felt really important to me to capture how poor organisational or workplace cultures and inadequate leadership were factors in this area, that a doctor's recovery from such events could be severely hindered by culture and leadership, particularly in environments where there was constant exposure to excessive criticism, high intensity work, and loss of control. And we know as psychologists, these factors really do prevent good working relationships in the organisation. What I knew was also, by contrast, that organisations where leaders could openly acknowledge fallibility and imperfection, and where they could create spaces where dialogue could happen after adverse events, recovery and healing were markedly improved. In late 2018, I published, along with Joe and with Rachel, my systematic literature review in BMJ Leader, and I started my study to look into lived experiences. So the participants in my study were, it was a purposive sample, were all doctors who'd experienced second victim phenomenon following medical error or a near miss or an adverse event. To recruit them, I utilised my professional network and some social media platforms to invite doctors who were willing to share their experiences. Interestingly, although eight were eventually interviewed, 16 expressed an interest in participating, but not all of them felt well enough or stable enough to conduct those interviews with me. My final study included 8 doctors, 2 were female, 6 were male, and at the time of the significant event, their roles were varied: consultants, specialist trainees, and junior doctors, and those specialties ranged over A&E, anaesthetics, psychiatry, and surgery. So the methodological approach that I took was interpretive phenomenological analysis, IPA. It's a really collaborative way of having an interview where the participant is the primary expert. It features small sample sizes, so a sample of 8 was certainly okay. And one of the reasons for that is because it really allows you to take a detailed, in-depth exploration of each participant's experience, and that wouldn't be feasible with larger samples. The interviews themselves didn't follow a rigid prescriptive format. Instead, they allow for a flexible dialogue. I did use an interview schedule as a guiding framework, but essentially, that was just to ensure that the key lines of inquiry or areas of my inquiry were addressed. My first question to each doctor was, can you tell me the story of your experience? And this was just designed to help them to speak in an uninterrupted way about their personal experience. And often I didn't have to ask much more. However, the 8 interviews that were conducted amounted into nearly 9 hours of conversation, 102 pages of transcripts that I transcribed myself, 55,000 words, 3,700 lines, and each of those lines went through a meticulous line-by-line analysis, along with repeated readings and frequent revisits to the original recordings. For much of the process, the doctor spoke and I listened, and for some of them, it was the first time that they'd ever spoken about their experience, and others said that sometimes it was the first time that actually anyone had truly listened to them. I felt really privileged to hold that space for them. And whilst there are lots of ways of looking at IPA, the way the picture here, the way that I found most helpful for me was to use a pinboard and sort of each transcript, which each of those cards show, was stuck onto a physical board to just help me visualize and clearly understand the emerging themes. So from this analysis, there were 3 superordinate themes which emerged, which I've eventually named impact, perceptions, and leader support. And perhaps with what I'm about to share with you, there are 2 important things to say: that some of the verbatim that I'm sharing is distressing and contains suicidal content, but also I might refer to a doctor's name, and obviously that is fictitious to protect their identity. So the first superordinate theme here is impact. And within impact, there were 3 sub-themes, and I'll briefly discuss each sub-theme and just try and bring out and give examples of the research. So sub-theme 1, psychological morbidity. And here we have an excerpt from the verbatim. I was going to throw myself off the car park. We know that there's a huge psychiatric impact of second victim phenomenon. And I know that Kevin's also in the audience. So Kevin Teo, his work with Gail Kinman indicates the prevalence of that after traumatic events, healthcare professionals often experience anxiety, depression, insomnia, rumination, and also suicidal ideation. And we know too from the recent data from the Office of National Statistics that in the UK alone, 72 medical professionals, including doctors, nurses, therapy professionals, and dentists, completed suicide in 2020. And we know that suicide is particularly prevalent amongst nurses. 360 attempted suicide in 2022. But the ONS data doesn't really capture the true numbers, and neither do the numbers tell the exact story. Behind every number, there's a heartbroken family and a friend who live with the sad event. And within my interviews, doctors expressed deep despair. 2 in particular attempted suicide, a reckless near-death experience, and a plan which was only to be saved by a colleague's intervention. The other thing in terms of psychological morbidity was also the insomnia and anxiety. And I saw symptoms, or I certainly heard symptoms where medication was required to cope with depression. And there was a real dread about driving through the hospital gates in the morning following the event. Also, the lingering rumination that doctors experienced. One particular doctor was haunted by a misdiagnosed patient's death many years later, and it demonstrated that the trauma continues to affect their mental health. The second theme was about the doctor's felt experience, and this is indicated here by one doctor who said, nobody talks about it. And perhaps just to explain that, there would, without doubt, a profound sense of shame and guilt that was felt after medical incidents. One doctor had struggled to tell his family, in particular his father. He'd been on garden leave for a year before he actually explained to his father what had happened. Another doctor experienced guilt and anxiety over potential scrutiny and investigation following a patient's suicide, a real deep worry of the guilt and the shame that might be exposed in the coroner's court. There was also a sense of silence and isolation, that often people felt that they had to keep things to themselves. They felt abandoned, unable to talk to colleagues. There was no one to confide in, they often said. Sometimes they likened it to the emotional toll of being physically assaulted, feeling battered, describing deep despair, anger, and frustration, which led to a really significant decline in their quality of life. But also the prevailing culture of silence, that the lack of communication and support in the face of the medical error led to people not speaking to them and not being able to seek help. Without a doubt, the sub-theme of professional identity was incredibly present. You can't be seen as someone who can't cope, was what one doctor said to me. So there was a worry about professional or reputational damage, but also the need to have to mask their vulnerability. the paradox perhaps of medical error, that despite the inevitability that mistakes will happen in healthcare, doctors felt that they couldn't openly express their emotional struggles, and that this was without doubt a strain on their professional identity, but also leading to this internalized fear of failure and public judgment, which caused a culture of silence.